Welcome to Life by a Thousand Cuts, a podcast series about skin cancer surgery. I'm your host, Associate Professor Tony Dicker, and in each episode, we'll share practical insights to support your skin cancer surgical practice, from clinical tips and case studies to journal reviews and interviews with skin cancer colleagues. Today, we're looking at a case study, an example of how to do a closure of a larger lesion on the face. So let's get into it. Okay, so here's our case to have a look at. We have an 88-year-old male who has significant dementia and some Parkinsonian features. He's quite stiff and immobile. He is still cared for by his family at home, and the overall plan in discussion with him as well as the family is a relative conservative management. But he has presented now with this eroded bleeding lesion on his left cheek, and that's becoming difficult for them to manage. They're having trouble with this at home. So that's why they've said, I know the plan was to be not too interventional, but we need some help here, please. And here's that lesion. So on his left cheek, it's a pretty poor history of the lesion, but it does sound like it's been there for a few years. It doesn't feel like it's been too sore, but it's hard to determine that soreness from him. We can't get that sort of history off him. It certainly has been bleeding, and that's part of the reason why the family's brought him in, because they're having trouble controlling this lesion now. And it's not a matter of being there for a month. It actually has evolved over sort of a number of years where they've been able to manage it and finally said, look, we're now really struggling. So incomplete history, but you can see what the lesion is there. And the first thing I want you to think about is, what is your preferred diagnosis? This is a good part of the mental exercise of any sort of surgery. You should start with, what is my preferred diagnosis? What is my differential diagnosis? What diagnosis do I need to consider and not miss is the issue here. So you've now mentally yourself gone through that process, I hope. So the apparent slow growth, that led me more towards basal cell carcinoma rather than squamous cell, especially that erosion and bleeding. But I did consider a squamous cell or even an erosive melanoma, of course, an amyelonitic melanoma. And the other thing that I had to consider, that the history wasn't there for it, was, is this somehow self-induced? Is this him getting his fingers there and picking and scratching at something in a long-term way? And a chronic erosion of the area could also present in a very similar manner in this sort of age group. So then you've got to think about, what are your alternatives for surgery for this? Because we want to stay more conservative. And I suppose we've got to the point where the family have tried doing nothing and just putting dressings on there and have decided that's no longer a viable option. We should consider radiotherapy for this. Now, whether you do a biopsy first for diagnosis or whether you go straight to radiotherapy, I think if you were saying, let's do radiotherapy, you'd need to have at least a histological diagnosis for them to consider it. So you'd need at least a punch biopsy as a minimum to get a histological diagnosis and consider radiotherapy. You can also, in a very conservative way, just put some local anesthetic underneath this and get out a curate and just debulk the lesion. So it'll give you histology, so you know what the lesion is. It'll take away a lot of, or most of, the tumorous growth, and that can then be something which can then heal and be possible for the family to manage it. And it might be good for 6 months or a year even, where just debulking the tumor is enough to control it. And there's been a couple of times for patients in nursing homes where the lesion's becoming a concern and a problem, but they don't want heroic cures. They just want to sort of solve the problem. But I've done that. I've just debulked it with a curette, and that can work quite nicely. Then the other consideration, of course, is, do I have to get a histological diagnosis first before doing surgery, or can I just manage the person and get rid of this problem which the family's worried about? And there's lots of considerations each way for that. I'd suggest a punch biopsy rather than a shave biopsy for a lesion like this. When there's a lot of crust and erosion, and you just shave off the top, you might only just see inflammatory tissue and not actually identify what the tumor is, or make it harder to identify. So usually for the edges where it's a little bit raised on the edge, a punch biopsy through some of this tissue is more likely to give you the correct diagnosis for what's going on here. Then if we are going to proceed to surgery, the question then is, what margin do you take? Again, we haven't got a definite histological diagnosis. We're working on a preferred clinical diagnosis of erosive BCC and nodular or sclerotic. And you can see on this that there is also these areas of scar, little areas of scar off to the side. So it's not a well-defined tumour. So certainly in this sort of lesion, one of the considerations is Mohs micrographic surgery. When you're having trouble defining the margins, then referral to a Mohs surgeon can help in removing the entire lesion, or at least getting the margins for the entire lesion. So we have to look and feel, and as you feel this lesion and feel where it's indurated, then your minimal edges to get to the edge of this lesion is something like that. But if you then start including the scarred area as well, there's other areas you need to consider removing to get a more complete cure of this lesion. Which gets us to the point of, that's the sort of area that needs cutting out. We've got this scar up the top, we've got a margin around what was the indurated components. We're taking in a good 3 or 4 millimeters outside of that as well. And again, we're not going for 10-year cures for this lesion. We're not really looking for 5-year cures for this lesion. We're looking for control of this lesion for this particular patient, because the chance of him being alive in 5 years' time is probably less than 10%. He's at an end of life stage with dementia as he approaches nursing home sort of life. And so that comes into consideration with your planning of what to do here as well. We don't have to have a definite 5 or 10-year cure for this lesion. We need to control the lesion. So we're going to do a margin like that. So I want you now to go through that mental process of, how would I close this? If I'm going to cut this off and take those margins, what can I do to close the lesion? Can I do it as a primary ellipse? Is always part of your thinking. And just go through your hierarchical ladder of options for surgery, going through primary closure, through grafting options, through different types of flaps, through more complex flaps if you needed to. Just thinking through that process of how you would close this defect. So if you wanted to download this and pause the video now, you could actually also print this out from a screenshot and start doing some drawings yourself and actually make some plans of what you would do. There's multiple ways of doing this, not one right answer. Obviously, I've only done one surgical procedure, but in your thinking about it, this is a nice process to go through of what's going to work and why, what are the issues. So I decided to do a VY advancement flap. For this, the loose skin is inferior or lateral, so we can't move things from skin from towards the corner of the mouth because it's going to pull on the opening here. We can't really move skin from above because we start getting into issues of ectropium and pulling on the lower eyelid. The outside we can consider using to close a defect, or the skin below it. Now, an ellipse in this area was just a bit too big, unfortunately, so it was nearly an option, but not quite. It was too large a cut to close by an ellipse. So in this circumstance, I decided on a VY, but certainly a rotation from laterally. If I'd cut out towards the ear and then rotated down in front of the ear and rotated that part of that lateral part of the cheek up to the middle to close it. Or if I put a graft on there, it would actually also fulfill the needs. We're trying to get control of this lesion rather than cure. This patient isn't worried about the aesthetics, so it's not a major issue. It's relevant, but it's not the major issue in this circumstance. But these are the ways you need to think about how you would approach this sort of surgery. So we've got a lesion which is nearly 3 centimeters by 3 centimeters. We remove that, and there's the defect we have to close. And we're going to take this skin from below it to move it up. To do this, we first of all closed that little triangle at the top. So you don't have to move the whole flap into there. If you can decrease the size of the defect by taking out some small little dog ears, that means there's less tissue to have to fill as a whole compared to what we had before. So that triangle can close and then fill a smaller defect. And then we undermine these areas laterally. So with a VY advancement, all of the blood supply comes from the base of the skin, the donor skin here. So if you undermine this, you're cutting off the blood supply. Your undermining is out to the side here, out to the side over there, and that allows the tissue to slide up on the base when the undermining is under here. That's important we don't undermine and remove the blood supply from this. Then we use some deep sutures to hook it into place. So I've started with effectively two. I've started one here, the second one is going there, which you can see is holding it in place, and a few more to hold it into the side to start getting placement of the flap. So a couple of deep sutures to hook it into place to start with, and then we use our surface sutures to tidy up and sew it out. So again, I tend to start from the top and work my way down each side. Sometimes by starting at the base and pulling the skin together can also help push the advancement forward. Didn't require it in this circumstance, that extra push forward. It was actually more starting from the top, getting nice placement, and then smoothing out these edges as we went down each side, and then finding out what was left that required sewing here at the base. So the important thing for this was the direction of pull. Is there was some downward pull from the top. As we pulled this skin up, there's also the counter tension downwards, but there was no ectropium. As you can see here on the right, his eyelid is in good contact. The direction didn't actually pull on his eyelid and cause ectropium and weeping eyes. That was one of the features I was very conscious of when I was designing this. Now we got our histology back, and it came back as a poorly differentiated squamous cell carcinoma. So obviously this had been there for a while and it just evolved into this state. We had no perineural invasion, which is good, and we had a histological clearance of at least 4 millimeters laterally and 4 millimeters to the deep margin. So histological clearance is different to a clinical clearance. We created a margin of around 3 or 4 millimeters clinically for a poorly defined tumour, and we ended up with a 4 to 5 millimeter margin histologically, which is good. So with a poorly differentiated tumour, you would consider taking a wider margin clinically, but histologically we're showing it's well clear. With a poorly differentiated tumour, you would consider follow-up radiotherapy, but it didn't become relevant for this patient. It was discussed with the family, which they were happy to decline, and I think that was quite appropriate for his circumstances. This patient, radiotherapy was not going to be required. This was, again, a more conservative management was the plan, despite the size of the actual surgical procedure. So we've got tumour clear, we've got control of the lesion, we've got something the patient can manage. He kept on going. A year later, this man could no longer walk. The family could no longer care for him. So he's now in a nursing home, dementia, immobile. But in his nursing home care, there's no problem on his cheek. This is not an individual problem he has to manage anymore. He's healed remarkably well, as you can see. This difficult to identify scar is where we've moved the skin forward. The advantage for this is it's easier to shave. So he'll have extra hair, which we've moved up. We've moved the hair from the jawline up the cheek. So this area will require shaving to manage it as well, but that's easy to do. There's no weeping, bleeding lesion for him. So there's this case. That's just, as I said, one way of closing the lesion. There's multiple options. We've achieved all our objectives, I suppose, is the main thing. We wanted to get the patient in a stage where it was easier to manage. We stopped the bleeding, and it has healed nicely, as you can see. So that's all I wanted to cover today. Hope you found this episode helpful and perhaps even picked up some practical tips to use in your clinical work. A big shout out to HealthCert for all their help with production and distribution of this episode. They do a lot of good things in skin cancer education, including helping get this podcast to you. Thank you for listening, and I'll see you next time on Life by 1,000 Cuts.